A very good afternoon to all of you. At the outset, I would like to thank AIOS for giving me this opportunity to present my views on this topic before you. So, I would like to ask how many of you who are doing the treatment of microbial keratitis are routinely performing the microbiological culture or smear testing. So, ideally, what the approach is recommended is after your clinical diagnosis, it should be confirmed with direct smear and microbiological culture and sensitivity, and then specific antibiotics should be started. But practically, that is when solo practitioners are concerned, that is never the case. This is a study done by LVPI in which even more than 90% of solo practitioners were giving empiric treatment only, and they were giving even corticosteroids without doing microbiology. So what is the reason of this behavior? When all the guidelines suggest us that we should do microbiology before starting the treatment in case of a corneal ulcer, why ophthalmologists are not doing? Because of the microbiological workup needs a well-equipped laboratory and microbiologist capable of dealing with small ocular samples. Then we need a trained staff, and it increases the cost and logistics, and this is difficult both for the ophthalmologist and the patient. And sometimes the microbiology may be repeatedly negative, whatever you do. And the culture reports take time. So until then, we have to prescribe an empirical treatment. So early and appropriate treatment reduces the morbidity in corneal ulcer, and sometimes the reports are unreliable. In that case, our clinical judgment is better than the lab reports. So to solve this dilemma, WHO conducted a workshop in 2005, and they gave us some guidelines. In those, if it is a significant number of corneal ulcers are bacterial, and most of the antibacterial agents are bactericidal, and their effect can be demonstrable within days. So it is advisable that if it is a mild corneal ulcer less than 2 mn, then you can start the antimicrobial treatment without doing any microbiology. But if you suspect fungus, then it is necessary to do a 10% QH test. You are not recommended to start an antifungal treatment without looking for the hyphae in the 10% QH test, which is a pretty simple test to do. But in large and serious ulcers, they should be referred for microbiology because the case may deteriorate and it may not be amenable to treatment after that. But the teaching institutions were advised to do microbiology in each and every case, so the epidemiology of the area is known. So if you want to target your target without seeing the target, you want to hit the bullseye, you need more knowledge actually. You need to know thoroughly about the history of the patient, the predisposing and risk factors of the patient, and in what geographic area you are practicing, whether you are practicing in rural area, urban area. It is well known that in North and West India, aspergillus is more common in fungus, and in South and East India, fusarium is more common. So you should know about the various clinical presentations about the bacterial, fungal, viral, protozoal, and non-infectious corneal ulcer manifestations. And the sensitivity patterns of the organisms should also be known. So you should form a clinical judgment. We should clearly differentiate between bacterial and fungal. So this is a study done by Schroff Eye Center in which more than 96% of the cases comprise of bacteria and fungi combined together. So if you are able to diagnose or differentiate between bacteria and fungal corneal ulcer, then half of your job is done. There were 2 studies in which clinical corneal specialists diagnosed corneal ulcer on basis of slit lamp examination only, and 3/4 of them were correct in their diagnosis. So how should we go about the empirical treatment? First, we should take the history about the duration, because there are certain organisms which rapidly progress and certain which are slow growing. Then trauma or any sac disease, conjunctiva, ocular surface disorder, any history of contact lens use, recurrence of disease, whether the patient has taken any past treatment and its response. And systemic factors like diabetes, immunocompromised status, etc. should be known. So certain risk factors, which are local risk factors, should also be taken into account, like entropion, ectropion, seventh nerve palsy, or dry eye, or any ocular surface disorder like vernal catarrh, neurotrophic, or bullous keratopathy. And then occupational risk factors should also be taken into account, like if the patient is farmer, animal handler, or gardener. So after that comes the evaluation part. So in evaluation, you should first look at the patient in general. What is the skin condition? What is the, if there is any leg ophthalmos, any eyelid abnormality, and check for the corneal sensations, visual acuity, and intraocular pressure. Then we should go in for the slit lamp examination. First, you will examine the eyelids. If there are any eyelid disorder, any MGD or any NLDO or any punctal abnormalities or tear film disorder like dry eye, and then you should look for conjunctiva, whether there is discharge, erythema, follicle, etc. And then you should look for sclera for inflammation, ulcer, and nodules. And then you should go in for anterior chamber examination, in which if you find this fixed hypopyon with convex margins, then it is most likely to be fungal with fungal hyphae in it. And if you are able to see this mobile hypopyon which moves when the patient moves their head, then this is mostly due to bacterial corneal ulcer. Then you should also document your findings, because then only you will be able to see whether the patient is improving or not. You should document the visual acuity, size and depth of the ulceration, stromal edema, infiltrate, and then the hypopyon AC reaction, intraocular pressure, and also B scan to rule out any endophthalmitis, especially in severe cases. So usually there are defense mechanism in eye which prevent corneal ulcer from developing, and most important from that are tear film, which has IgA complement, lactoferrin, our blinking mechanism which reduces the temperature of the eye, and then anatomical like intact corneal epithelium, eyelids, and bony orbit. So once the organism surpasses these protective mechanisms, the patient develops a corneal ulcer. So first of all, the patient will adhere to the corneal epithelium, and then infiltration will start. This is the stage of progressive infiltration. Then there will be active ulceration, where the size of the infiltrate increase and there is active necrosis. Then the body defenses and the antibiotics start working, and there is stage of regression. And finally, the inflammatory tissue is replaced by the fibrous tissue. And there is stage of cicatrization or scar formation, which we all want. So we should grade the corneal ulcer so that we can manage it properly. So mild corneal ulcer, less than 2 mm, something like this, less than 20% depth, superficial, and moderate corneal ulcer, 2 to 5 mm, 20 to 50% depth, and infiltrates reach up to mid-stroma. And severe corneal ulcer, more than 5 mm, more than 50% of the depth is involved, and they reach, infiltrates reach deeper than mid-stroma. So then we should note about clinical features. We all know about them. A patient will complain of redness, photophobia, defective vision, pain, discharge, and there will be signs like emesis, eyelid swelling, conjunctival injection, epithelial defect, and DM folds, and sometimes desmetocele or corneal perforation, and hypopyon. So once you have analyzed your patient, and you have a patient sitting before you who, where corneal ulcer looks like this, which is a mild corneal ulcer, less than 2 mm, 2 mm away from the visual axis, less than 2 plus AC reaction, it's not having any feature of fungal or parasitic ulcer, and not having feature of rapidly progressive ulcer, then you can go about treating that ulcer with monotherapy with fluoroquinolones. This has been proven in bacterial keratitis study that monotherapy with fluoroquinolones is as effective as fortified eye drops. So you can take any fluoroquinolone, but 4th generation gatifloxacin and moxifloxacin are preferred, and even the new levofloxacin concentrated 1.5% is also a good option. So you should start with a loading dose, which can be given in clinic itself every 5 to 15 minutes in the first hour. After that hour, it should be given hourly till 48 hours. And after 48 hours, you should examine the patient. And if you are seeing adequate response after 48 hours, then you should reduce it to 2 hourly. And then you should continue the treatment till reepithelialization occurs. And after that, you should continue 2 weeks after the healing. So to summarize, less than 2 mm ulcer, monotherapy with fluoroquinolone is sufficient. More than 2 mm ulcer, fortified cefazolin 5% or vancomycin, or ciprofloxacin combined with ciprofloxacin and like tobramycin 1.3% should be given. And there should be no steroids to be given in empirical therapy. Steroids can only be given if you have culture report with you. So after that, you should be able to see if the patient is healing or not. The patient will be more comfortable. The patient before he was not able to open their eyes, they will start opening their eye. There will be decrease in all the signs and symptoms of pain, lid edema, redness, discharge, infiltrate area, size, density, margins, and hypopyon. So if after 48 hours the case is worsening or it is not responding on empirical therapy and you have not access to microbiological workup, then you should better refer the patient. And also, if the patient is one-eyed, severe central perforated corneal ulcer or pediatric or post-LASIK or post-cataract surgery, contact lens induced, then hospital acquired also, you should refer the patient. Then these are well-rounded, well-circumscribed corneal ulcers with relatively clear cornea, which belong to gram-positive Staph aureus, and these are due to pneumococcus, which are rapidly progressive serpiginous ulcers with one active leading edge. These are gram-negative bacteria, ground glass appearance, greenish yellow discharge, and rapidly fulminant, perforates in 1 to 2 days also. And if the patient gives you history of farming background, then diabetes or any corneal epithelial disorder or history of trauma by vegetative material, then you should suspect fungal ulcer. There will be dry, thick hypopyon with feathery margins, with satellite lesions, with endothelial plaques. This is dematicious fungi with abscess and this fixed hypopyon. So you should start treatment. If then you should do 10% KOH staining, and if you are able to see fungal hyphae on that, you should start with 5% netamycin, 1 hourly in daytime and 2 hourly in nighttime, and then taper after 7 days. If the patient is responding, continue the therapy for 4 to 6 weeks and 2 weeks after healing. And after healing, after 2 weeks, you have to again call the patient. Then if the patient is worsening, you should add amphotericin B or voriconazole and refer the patient. So this is a TST protocol, which is very good. But if you are suspecting corneal fungal ulcer on clinical basis and no fungal hyphae is seen, then you have to refer the patient. So no role of steroids in empirical therapy. It is proved by SCUT, and adjuvant treatment like cycloplegic pain management, anti-glaucoma, and lubricants can be given. So these are differential diagnosis: wreath-shaped ulcer of nocardia, ring-shaped and ulcers, and this radial keratinitis of acanthamoeba, and these are microsporidial keratitis with coarse SPKs and stuck-on appearance, and all the rest of the cornea is clear. And this is the stromal microsporidial keratitis, which you should better refer. This is moraxella, which occurs in chronic alcoholics or diabetics and malnourished. This is a classic windshield appearance of atypical mycobacteria, and this is pythium keratitis, which looks like fungal, but it is very devastating. Even if you give all the correct medical therapy, usually patient lands up in surgical and you may even lose the eye. And these are non-infectious keratitis like foreign body granuloma, bee sting, drug toxicity, or VKC shield ulcer. So in summary, after you examine the patient in detail about history, predisposing factor, past treatment and response, systemic conditions and clinical feature, you should be able to make a clinical judgment about whether the person or patient is having a bacterial, fungal, viral, parasitic or non-infectious ulcer. And then you should start the empirical treatment. If the ulcer is mild, then start with monotherapy with fluoroquinolone. Observe and see the patient after 48 to 72 hours. If the patient is improving, well and good, continue. If the patient is not improving, then you have to refer the patient to some place where smear and culture sensitivity is done. And take-home message is that in empirical therapy, bacterial corneal ulcer with mild less than 2 mm can be treated with monotherapy, and severe microbiology should be done. And in fungal, you should do 10% KOH. If you see fungal hyphae, then 5% netamycin should be started. So to conclude, in this slide, I just want to show that when the patient goes to tertiary center, it is already, the clinical picture has already distorted. So when the solo practitioner sees the initial nascent picture of the patient, in which you can make out the textbook diagnosis by seeing the slit lamp also. So you are in good position to start an empirical treatment, but you should be having a good judgment when to refer the patient. Thank you.